Ik denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé, complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. Ja, je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra, di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione, tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero, per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva sucedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial, parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivää töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me, I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision making and has reduced that fear factor.
Honesty and humility go a long way, and most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that, what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc, voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato in questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori, sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possano pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
I'm a critical care nurse. I'm proud to work together with other professions as a multidisciplinary team to fight COVID-19. Together, we are intensive care.
I am an anesthesiologist and I'm proud to be an intensivist. Together we are fighting COVID-19. Together we are intensive care medicine.
I am a critical care nurse and perfusionist. I am proud to work in an intensive care unit. We are working together to fight COVID-19 and together we are intensive care medicine.
I am an internist and I am proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Good evening, ladies and gentlemen, and welcome to this webinar organized by the European Society of Intensive Care Medicine on individualized lung protective ventilation in ICU. I would like to thank the ESICM and also our support, the GL Care, for organizing this meeting that I hope will be interesting for everybody. Just a few words to remember to myself and to you that the origins of modern mechanical ventilation can be traced back about 5 centuries to the works of Vesalius, but don't worry, I'm not intending to speak about, to carry on all these 5 centuries, but just I think it is important to know our origins, to know where we plan to go, where we are going. Actually, probably from the first years of the last century, as soon as mechanical ventilation, positive pressure mechanical ventilation became worldwide used, we realized that together with the obviously important positive effect of the mechanical ventilation, there were also some problems, some side effects. We know that the first side effects were the ones related to high pressure. So the first concept that was developed was the one to avoid barotrauma. Later on, the scientific research helped us to understand that there is also a volutrauma. Later on, we started to speak about ventilator-induced lung injury and some mechanism of injury also linked to biological trauma were identified in the last year of the last century. All these excursus to recall to everybody that lung protective ventilatory strategies have been developed together to the development of much more important and kind of mechanical ventilation. So we are dealing with the possibility to better ventilate patients, but also with the need to avoid injury. That's why since more than 20 years, we are speaking about lung protective ventilation. But now, in the 21st century, medicine is going even forward, and as you all know, the future of research, the future of our profession will be personalized medicine or precision medicine, as somebody can prefer. That is a stratification, the medicine based on patient stratification to reach the most precise and more specific therapy for a specific group of patients, or ideally for a specific patient. So that's why I think it is particularly important, this the topic of this webinar, because we are speaking exactly of how to individualize lung protective ventilation. And we are doing this with two good researchers, two doctors, two intensivists that are a strong scientific background, and that I will start to present. The first speaker is Dr. Domenico GRIECO. Dr. GRIECO works in Rome in the Policlinico Gemelli hospital, but he has got his training also in Toronto with Professor Brochard, and is even very young, is the author of important papers published in top-level journals. So I'm very proud to introduce Dr. GRIECO, who will speak about the role on the ELVU measurement within an individualized lung protective ventilation strategy. Please, Domenico.
Thank you for the nice introduction, and many thanks to ESICM for the invitation to join this webinar. I'm delighted to be here today. In the next few minutes, I will discuss the role of end expiratory lung volume measurement to optimize and individualize lung protective ventilation with a main focus on ARDS patients. So I will start stating that some conflict of interests. One is related to this topic, as I've been assigned a research grant and study by GE Healthcare. So I think that speaking about ARDS, one of the greatest advances in the last 30 years is the understanding that the ARDS is strictly linked to the concept of the baby lung. So mechanical ventilation is injurious in patients with ARDS because the volume in which the tidal volume inflates is much lower than the volume that receives tidal volume in a healthy person. And unfortunately, we do not have any reliable estimates based on a height and weight about the volume of lung in which the tidal volume inflates. This is a milestone study showing actually that the only estimate of the size of the lung in which the tidal volume is inflated is the compliance, which is a very good link with the, let's say, FRC, so the functional residual capacity, so the amount of gas in which the tidal volume inflates. And experimental studies showed that the major determinants of ventilator-induced lung injury, which also correlate with clinical outcome, is the dynamic strain, which is the ratio of the tidal volume, so the amount of gas that is inflated in the lung, to the FRC, so the size of the lung in which the tidal volume is inflated. The reduction in the FRC, so the lung volume loss in the ARDS, is greatly heterogeneous and depends on many characteristics based both on patient's characteristics and on disease characteristics. And we have data showing that actually patients, also healthy volunteers, submitted to mechanical ventilation with different dynamic strains on different ratio between tidal volume and FRC, show a different degree of ventilator-induced lung injury. And we have been learning in the last decades that the aim of mechanical ventilation should be both the correction of hypoxemia and hypercapnia, but mainly the avoidance of ventilator-induced lung injury, VILI, which is strictly correlated with the clinical outcome of ARDS patients. And in this nice study, published in Intensive Care Medicine in 2012, they found a very significant threshold for the dynamic strain, essentially showing that once the dynamic strain, so the ratio between tidal volume and functional residual capacity, is greater than 0.25. So let's pretend that the lung volume of a patient, the end expiratory lung volume at seat, so the FRC of a patient is 1 liter. Once the tidal volume exceeds the ratio between tidal volume and FRC, which is 0.5, so a tidal volume exceeding 250 milliliters, well, this is associated with an exponential increase in the risk of ventilator-induced lung injury. So we don't have tools. We have tools to estimate the size of the aerated lung, but we are starting to have tools also to measure the absolute lung volume, so to know the number of alveoli that are ventilated at the end expiration, so the size of the FRC. This is a simple method which is based on a Fick rule, in which you change the dilution you change the inhaled fraction of an inert gas, which is the nitrogen. The nitrogen is the balancing gas of the air. So you change the FiO2 to the patient. This changes the amount of nitrogen that is inhaled by the patient, and the time in which you reach a new equilibrium is strictly related to the size of the FRC, or the lung volume, which is aerated by the tidal volume. This is a step that is included in a mechanical ventilator and allows to measure end expiratory lung volume both with and without PEEP. And this could be something which could be very useful to titrate ventilator setting based on the individual requirement of the patients, because we know that we can reduce dynamic strain, which is the ratio between tidal volume and FRC, either by reducing the tidal volume or by an increase in end expiratory lung volume with alveolar recruitment. And but we know from studies conducted in the 2000 that the response to this intervention is highly individually variable. So we need to, I think in the future, research is focused on the aim to individualize treatments based on the individual response. So speaking about PEEP, we know that PEEP in the setting of ARDS should always be a fine-tuned balance between the unavoidable overdistension produced in the aerated part of the lung, which is the baby lung, which is the part here that is already aerated at low PEEP, and the possibility to recruit new alveoli, which increase the denominator of diffraction and at the end reduce dynamic strain by increasing the end expiratory lung volume. And we have learned from Professor Gattinoni's studies that these are milestone studies clearly showing that the response to PEEP is greatly heterogeneous. This is a classical slide in which you can clearly see the different response in two patients. On top, you have a higher percentage of potential for lung recruitment. You see that increasing PEEP from 5 to 45 centimeters of water does not add any, does not recruit any part of the dorsal part of the lung. In that case, the effect of PEEP is only overdistension in the of the aerated part of the lung, of the baby lung. And also look at the heart, because the heart is squeezed by the increasing pressure. And this is one of the harmful effects of PEEP. And squeezing the heart means increasing the afterload of the right ventricle and increasing the risk of cardiac dysfunction, which accounts for many deaths in patients with ARDS. In the bottom part of the slides, instead, you see that there is a patient in which the increase in pressure in the airways generates a huge recruitment in the dorsal part of the lung. You will clearly understand that if you keep tidal volume constant, the effect, the deleterious effect, so the harmful effect of tidal volume will be reduced by PEEP in the second condition when the pressure is high, because the tidal volume inflates in a larger lung, so and the dynamic strain is reduced. So PEEP should be a fine-tuned balance and between the capability to protect the lung by stabilizing recruitment, reducing strain and prevention of arterial trauma, but high PEEP in patients with low potential for lung recruitment can lead to barotrauma, worsen hemodynamics, increase the need for a positive fluid balance with the final effect of increasing mortality, prolonged weaning from mechanical ventilation. So as a general rule, I think there is time, this is the time to individualize PEEP in patients with the ARDS based on an individual response. And as a first rule, we have data to suggest that in patients with a PF ratio which is not very low, so in moderate cases, we have learned that it's not needed to use high PEEP. PEEP between 5 and 10 is okay because the potential for lung recruitment is usually low in patients with mild hypoxemia. So ARDS and PF ratio between 200 and 300. In 300, we may have some benefit from high PEEP, but it is reasonable to suggest that this benefit is limited to the patients who have high potential for lung recruitment. With a large group of investigators led by Lu Chen and Laurent Rochard, we developed and validated a simple method to assess recruitability at the bedside. This method is derived from the conventional pressure volume curves of the respiratory system and can be made by any ventilator at bedside. Essentially, what we propose to do is a simple de-recruiting maneuver. So you see a patient that is ventilated in volume controlled mode. Here you have the flow, the pressure, and you have PEEP 15 set here, and this is the volume, so the tidal volume, 400 milliliters. If you reduce respiratory rate and you abruptly reduce PEEP by 10 centimeters of water, you have an increase in the exhaled tidal volume, which is very close to the amount of change in lung volume caused by PEEP. So the recruitment is very similar to recruitment. From a simple formula that essentially takes into account the compliance of the respiratory system, you can separate between the change in lung volume, the amount of gas that is recruited, and the amount of gas which is caused by overdistension of the baby lung. And by simply making a ratio between the compliance of the amount of volume that is recruited by 10 centimeters of water and the compliance at PEEP low, which is an estimate of the size of the baby lung, you obtain an recruitment to inflation ratio, so RE ratio, which is an estimate of the potential for lung recruitment. We have seen that there is high recruitability, or at least high potential for lung recruitment when this recruitment to inflation ratio is greater than 0.5. If you wish, you can just check this website where you can make calculation, and there is a video to do it at the bedside with any ventilator. So this recruitment to inflation ratio essentially is the amount, is based on a 3-compartment model in which you normalize the amount of recruited lung, so the yellow part here, to the size of the baby lung. It is clear here, for instance, in this patient, that there is amount of a good recruitability compared to the size of the baby lung of the patient that is obtained where the PEEP is increased. The other, however, I will show you some new data, because with the recruitment to inflation ratio is something which actually estimates the amount of recruitment between two PEEP levels that are very far. So I'm showing you a case, for instance, in which the recruitment to inflation ratio obtained with this single de-recruiting maneuver was 0.5. So actually in between the definition of low and high potential for lung recruitment. What we have done in Rome is running a PEEP trial, so measuring the end expiratory lung volume with the nitrogen machine washout technique at each PEEP level. And for each PEEP level, we calculated the recruitment to inflation ratio of each PEEP level. And we were very surprised to see that actually in this patient in which the potential for lung recruitment was on average, so it was not a clear indication whether to use high or low PEEP, the recruitment to inflation ratio for each PEEP level was greatly heterogeneous, meaning that there was a huge potential for lung recruitment if you look from 5 to 10 centimeters of water, while there is no more recruitment from 0 to 15 centimeters of water. And this is the rationale for a study that we will be launching in next year, in which we will try to set PEEP based on the individual response of the patient based on the measurement of end expiratory lung volume with nitrogen wash-in wash-out technique at different PEEP levels in patients with moderate to severe ARDS. However, as we have said before, that the possibility to reduce dynamic strain and individualized treatments is not only based on the recruitment, so the reduction of the dynamic strain by alveolar recruitment, but the numerator of the formula for the dynamic strain contains the tidal volume. This is why we know that the tidal volume, so limiting the tidal volume, is probably the most effective intervention to reduce mortality and improve survival in patients with ARDS. And from basis physiology and from the studies published by the Professor Gattinoni about the baby lung, we know that the compliance is the more close estimate of the FRC. So if we think about the ratio of tidal volume to FRC, which is the dynamic strain, the ratio of tidal volume to compliance could be a very good estimate of the dynamic strain. And importantly, this ratio, tidal volume divided by compliance of the respiratory system, is the driving pressure, so plateau minus PEEP. And this is why the driving pressure has been shown to represent the most relevant ventilatory variable to impact patients' outcome in a milestone study published in the New England Journal of Medicine by Marcelo Amato and a large group of investigators. And we know that the driving pressure is much more relevant than the tidal volume normalized by predicted body weight. So ideally, we should not set tidal volume based on the predicted body weight, which is an estimate of the size of the entire lung, but we should think of setting the tidal volume based on the real lung size, which is really heterogeneous between patients and patients because the entity of lung volume loss caused by ARDS is heterogeneous. And in this study, in fact, they showed that the best predictor among the ventilatory variables was the ratio between tidal volume and compliance of the respiratory system, which is an estimate of the dynamic strain, so tidal volume set based on the size of the actually ventilated lung. And this is the rationale to advise for clinicians to reduce tidal volume, even if you set 6 milliliters per kilo, which is the one suggested by the ARDS network when the driving pressure is lower than 14 centimeters of water. When you have a driving pressure then is greater than 14 centimeters of water, it is likely that the tidal volume is too big for the size of the aerated lung you are ventilating. And I want to thank Professor Giacomo Bellani and the colleagues and friends from Monza because they made a study and I have the privilege to show the preliminary data in which they really cleverly tried to set the tidal volume based not on the size of the predicted body weight, so not as we usually think, but based on the size of the aerated lung measured by the nitrogen wash-in wash-out techniques. So they just set the tidal volume on patients' predicted body weight, and then they tested whether it is feasible to set the tidal volume to have the tidal volume that is exactly the 25% of the unstrayed end expiratory lung volume. This 25% comes from the study I showed at the beginning of this presentation, in which we showed that when the dynamic strain is lower than 0.25, the risk of ventilator-induced lung injury is low. And essentially, making a long story short, they showed that the possibility to set tidal volume in patients with ARDS based on measurement of and expiratory lung volume is feasible. And what was really interesting, that if you put you set the tidal volume based on the predicted body weight, the inter-individual variability in tidal volume is very low. When you go to set the tidal volume to obtain a dynamic strain, which is associated to a lower risk of ventilator-induced lung injury, you generate lower driving pressure, and there is an inter-individual variability of this ratio between tidal volume and predicted body weight, suggesting again that the ARDS is heterogeneous, and the size of the aerated lung which receive the tidal volume is greatly heterogeneous and should be taken into account when we set the ventilator. This leads to the conclusions of my presentation, and I will say that measurement of and expiratory lung volume is an advanced respiratory monitoring technique which is gaining interest both to reduce the tidal volume in patients which the risk of overdistension is higher, and may help to set PEEP based on the individual response of the single patients in a context in which the disease is greatly heterogeneous, and so it is the response to ventilatory treatments. Thank you very much.
Thank you, Domenico. And let's switch to the second speaker, which is Professor SZULDRZYNSKI from Poland. Professor SZULDRZYNSKI is the head of the Department of Anaesthesiology and Intensive Care of the Central Clinical Hospital in Warsaw, and has also a strong history of as an intensivist, because he has been the co-founder of the Polish Society for the Development of Critical Care, and also is a member of a steering committee of many ESICM studies. Professor SZULDRZYNSKI will speak about personalized management of severe hypoxemia in the ARDS patients. Please, Konstanty.
Thank you very much for this kind introduction. It's really intimidating for me to speak about mechanical ventilation to the Italians, so I hope you excuse some faults that we may discuss later on. So the topic is management of severe...
Konstanty, please, could you speak loudly?
Yes, so the topic is the management of severe hypoxemia during mechanical ventilation, and we should take into account that the severe hypoxemia leads not only to the death of a patient, but also to the severe decline of the cognitive impairment and permanent neurological impairment in the survivors of ARDS, as you can see in this study of CT scan in those who survived ARDS compared to the healthy subjects. So probably we should aim at normoxemia to avoid not only elevated mortality, but also this neurological impairment. But in fact, what is hypoxemia and what should be our target for normoxemia? It's not an easy answer, because several studies, this is the study from this year, with only 12% of patients with ARDS, altogether nearly 3,000 patients, but aiming either 60 millimeters of mercury or 90 millimeters of mercury of the partial pressure of oxygen made absolutely no difference in survival. So that means that we could try to aim at lower targets, approximately 90% of saturation, which was also the outcome of this study published last year. It was terminated prematurely due to several adverse events in the low oxygenation target group. But even though the result was not significantly statistical, it also showed that at least there was no difference between the low oxygenation and high oxygenation groups. So we may try to aim at lower oxygenation targets. But how should we address it? First, by increasing oxygen delivery. We may do that by optimizing mechanical ventilation, by adjusting PEEP or performing recruitment maneuvers, also, and very importantly, by putting the patient in prone position, but also by reduction of pulmonary shunting. But to do that, we should understand its nature. Also, we should not forget about the ability to reduce the oxygen consumption, because we can do that by administering paralysis, for example, and also adequate sedation. We can also try to control hypothermia, so control fever, and perhaps in near future, the hypothermia could be also an option, as it is tested in sepsis and septic shock. And perhaps there is also some potential for beta blockers. Anyway, keeping this balance between increased oxygen delivery and reducing oxygen consumption is probably the way to manage the problem. So how should we optimize the oxygen delivery? The first parameter that we would like to address is oxygen concentration, and the second would be PEEP. But what is the best PEEP is the never-ending discussion. But probably for those patients with severe ARDS and profound hypoxemia, higher PEEP makes no difference for survival. However, it makes a huge difference for improving oxygen delivery. So even though we don't have clear signal for the entire ARDS group that high PEEP improves survival, it certainly improves survival in responders and in severe ARDS, but it for certain improve oxygenation. So what we should do in ARDS patients with severe hypoxemia is to increase PEEP, but there is a price to pay. As it was showed in dog studies by Göran Hedenstierna from 80s, you can see how the alveoli and alveolar capillaries look in normal animal ventilated with 0 PEEP on the left. And you can see what happens on the right when we apply PEEP. What happens is the closing of the alveolar capillaries, except for so-called corner capillaries. The result is the accelerated blood flow through the corner capillaries and redirection of all the other flow, of all the other blood flow to the poorly aerated regions. So the price that we have to pay for hyperinflation of the lung is the redirection of the flow and functional dead space. As you can see in this slide, there are quite different points of PEEP where there is optimal oxygenation and optimal compliance. So in those patients with severe hypoxemia, we should aim at perfect oxygenation, but look at the graph at the top, at the price of increased dead space, unfortunately. So this is way far from the PEEP levels of the best compliance. So this is quite interesting, and it shows that there is in fact no perfect PEEP. There is perfect PEEP from the points of lung protection, but in terms of severe hypoxemia, the levels of PEEP should be quite different, which was also showed in this famous study, a secondary analysis of LOVS and EXPRESS trials. There were the trials that based on different approach to setting PEEP, either on respiratory system elastance or based on oxygenation. And the result of this post-hoc analysis of both trials showed that in those patients in whom increased PEEP led to the decrease of oxygenation, it also led to increased probability of death, whereas PEEP proved to be helpful and rendered benefit for those in whom the oxygenation benefit was significant. So higher PEEP for sure helps those who are PEEP responders, who are recruitable, and in whom this very PEEP increases oxygenation or improves oxygenation, as you can see in this slide, and also in slides showed by Domenico, differentiating those who are PEEP recruiters and non-recruiters. Because as you can see, what we do applying excessive PEEP is causing hyperinflation in those parts of the lung which are relatively healthy or aerated or able to be ventilated. So what we do if we don't get enough recruitment is that we cause hyperinflation. There is certainly always some hyperinflation, but keeping that in mind is very important. Perhaps sometimes in some instances, PEEP titration using the esophageal balloon makes perfect sense, as in this small study from the times of swine flu, where the esophageal catheter was introduced to partition the respiratory system elastance between the elastance of the chest wall and the elastance of the lung. And when the elastance of the chest wall was high, that was, the chest was relatively stiff, there was room to increase PEEP, and those patients avoided ECMO. Whereas if there was no room for increase of PEEP, those patients required ECMO because there was no room for further mechanical ventilation improvement or optimization. Also, recruitment maneuvers may be useful sometimes, although their effect can be very short-lasting. They at least show us the room for optimization of mechanical ventilation and the potential for the recruitment of the patient. However, this trial, this ART trial, showed that refractory hypoxemia was equally present in the group with high PEEP and recruitment maneuvers and low PEEP. So probably recruitment maneuvers as a routine are not a very good idea, but as a means of diagnosing the potential for recruitment and differentiating the patients with optimal PEEP and too low PEEP, still the recruitment maneuvers have some place. What about prone position? Before the COVID, it was used in only 1/6 of severe ARDS patients, and it helps, which was proven in PROSIVA study and also earlier studies in the severe hypoxemia group, in the group of patients with PF ratio of below 150. But it should be applied early and also kept for a long time, 17 hours as used in the PROSIVA study. What happens in COVID-19 in terms of prone positioning? You can see that it improves oxygenation significantly. So it helps in terms of better oxygenation, not only in terms of survival. And interestingly, the response to PEEP is a very good predictor of mortality, as was showed in this British cohort. If the patients do not respond to prone positioning, the probability of survival is much higher, and they are probably the best candidates for early ECMO institution. But we should also understand the concept of shunt. The shunt is the amount of the blood that perfuses poorly oxygenated, poorly ventilated regions, which mixed with a well-oxygenated blood makes something called venous admixture. And the proportion of the venous admixture to the total arterial blood flow in the lung is the shunt fraction. And the shunt can be a result of different factors. It can be due to large functional dead space and also due to too high PEEP. It can be due to the opening of arteriovenous anastomosis or the flow redirection to the non-aerated regions, and also by accelerated capillary flow, as I showed you on this example of the corner capillaries. And interestingly, the catecholamines that we often use, they cause the opening of arteriovenous anastomosis and increase shunt significantly. So these are the drugs that we cannot avoid, but the price to pay is not only in terms of hemodynamics and peripheral perfusion, but also in increased shunt. Interestingly, this depression of cardiac output by beta blockers, for example, can be a good way to decrease shunt fraction, which was also proved by the group by Jean-Louis Vincent, who administered propranolol and decreased the shunt fraction significantly and also increased oxygenation in those patients. What about inhaled nitric oxide? It acts from the side of the alveolus, leading to the opening of the capillaries surrounding well-ventilated alveoli. So it redirects the flow to the better ventilated regions. However, many meta-analyses show no survival benefit. So what about oral vasodilators? Unfortunately, the oral vasodilators act in the entire lung, leading to the increased shunt fraction. So that's not the way to go, as you can see by the increased shunt. So maybe we should transfuse the patients. This quite recent study comparing those patients with ARDS with and without ECMO, transfused at aiming at 10 grams per deciliter or 8 grams per deciliter, and unfortunately there was absolutely no difference whatsoever. So aiming at higher levels makes absolutely no sense, except for the ability to wean those patients from the ventilator, but that probably has something to do with their muscle strength at the moment that you want to wean them. Optimization means reducing the oxygen consumption, and one of the most important factors are the respiratory muscles, because especially in acute respiratory distress, the high respiratory drive may account for up to 40% of the total oxygen consumption. So turning that off and sparing this oxygen for the entire body may also be a way to address severe hypoxemia. So this accuracy study published several years ago revealed significant benefit in survival in those patients, which was also confirmed by this meta-analysis from 2013. However, in the latest study published 2 years ago, this benefit in survival was not significantly, was not statistically significant. So probably administering neuromuscular blockers, even though they improve significantly oxygenation, should be reserved for several groups of patients. One of the groups of patients in whom administering neuromuscular blockers makes perfect sense are the patients with preserved respiratory drive, because high fluctuations, high swings of the esophageal pressure and transpulmonary pressure may lead to increased lung injury, but also to some de-recruitment, because the effective PEEP may be below 0, leading to the further atelectasis. So when should we use neuromuscular blockers as a salvage therapy in severe hypoxemia? That's for sure. Probably also for the effective control of excessive respiratory drive, and also for the management of asynchrony, because asynchrony impairs oxygen delivery and increases oxygen consumption. Maybe a temperature control would be an approach, which was showed by the purely physiological approach. As the oxygen consumption increases in fever up to 25% per 1 degree of Celsius, that would make perfect sense to decrease the temperature, as was showed in sepsis. And the ECMO. The ECMO is the ultimate solution for severe hypoxemia. But the better results, the earlier it's instituted, the better are the results. So don't wait too long. So to sum this up, severe hypoxemia is the risk not only for survival, but also for the long-term neurological function. We should improve oxygen delivery by optimizing mechanical ventilation and ventilation to perfusion ratio, by PEEP titration and avoiding excess shunting. Prone position is a good solution in most patients, probably approximately 80% of patients are the prone responders. And do not forget about the possibility to decrease oxygen consumption by the control of respiratory drive, by proper sedation and neuromuscular blocker administration, and also by fighting fever. But do not forget also that the response to PEEP is not only, is also the symptom of increased mortality risk, and those patients are the good candidates for ECMO. And there are some new perspectives, but we should keep in mind that whatever approach we use, the time is of the utmost importance. We should fight the severe hypoxemia as fast as possible, not to keep the patient paralyzed too long. Do not keep them on non-protective ventilation too long, and the time to institution of ECMO makes absolutely huge difference. Thank you so very much.
Thank you, Konstantin, for the very interesting speech. There are some questions from the audience. The first one is to Dr. GRIECO. The question is, what about the adoption of the stress index developed, as we know, from by Professor Ranieri? What do you think, Domenico?
So, I think that the adoption of the stress index is based on the principle that the intratidal compliance changes once the tidal volume is inflated. So essentially, it changes the slope of the last part of the pressure curve during volume-controlled ventilation. And this is definitely another way to identify patients who are at higher risk of barotrauma in case tidal volume is set at 6 milliliters per kilo. So if you see a stress, I definitely agree that if the stress index is greater than 1 and the tidal volume is set within a so considered safe range, this should lead to a reduction in the tidal volume. This could be another simple tool at the bedside to identify patients with a higher risk of barotrauma. But still, the stress index is mostly related to the stress provided to the lungs, so the total amount of pressure, which is another determinant of ventilator-induced lung injury. What we've been talking about is the strain provided to the lungs, so the ratio between the tidal volume and the FRC. Stress and strain are the two main components determining ventilator-induced lung injury in patients with ARDS, and we've been learning that this is the case also in healthy lungs during general anesthesia.
Okay, thanks. There is a second question, which is if it is better to keep driving pressure as low as 14 or less, but what about severely ill patients with severe hypoventilation and lethal pH and CO2 values in spite of maximizing respiratory rate? I don't know if Domenico, probably it is for you. You can answer.
I think this answer is this question is really up to date because the contribution of respiratory rates to the risk of ventilator-induced lung injury has for 8 years been, let's say, misunderstood. And there is a very nice publication by Marcelo Amato and co-workers in the Blue Journal, I think it is still in press, in which they analyze the relative contribution of the driving pressure and the respiratory rate and try to provide a simple equation trying to account to the relative contribution of each of the two parameters to the risk of mortality. Essentially, what they show is that the reduction in driving pressure is valuable until the increase in respiratory rate needed for achieving this reduction in isocapnic conditions is lower than 4 breaths per minute. On the opposite, if you need to increase to reduce 1 point of driving pressure, you need to increase respiratory rate more than 4 breaths per minute. It is probably valuable to keep the driving pressure a little bit higher. The meaning is that we don't have to look at the driving pressure alone, but to assess the risk of mortality, we should combine the driving pressure and the respiratory rate in terms of isocapnic conditions, and the relative contributions of these two parameters is 4:1. So the driving pressure is 4 times more relevant in determining clinical outcome as compared to the respiratory rate, which obviously is also linked to clinical outcome.
Okay, thanks. A question to Konstantin, which is, the question is, what is the role of propranolol in a patient with hypoxemia?
So for now, from the clinical point of view, there is absolutely none, because these were only the preliminary studies and there is absolutely no proof in randomized controlled trials of the use. I believe it was the study based on physiological rationale, just to prove the impact of the beta blockers. Now, the action of beta blockers is based not only on the reduction of pulmonary shunting, but also some data show that they also decrease the oxygen consumption by decreasing the mitochondrial activity, especially in sepsis. So it might be a way to go, but it's far too early to tell.
Okay, I would like to add my personal question. What about nutrition, the role of nutrition, which is not obviously something that acts rapidly, but what do you think? There are special suggestions in this case for hypoxemic patients?
Yeah, so for sure there is an impact of nutrition. One is that the nutrition sometimes is difficult to perform in those patients, especially if you put them on neuromuscular blockers. Second is the impact of the nutrition on the production of CO2. And if the adjustment of mechanical ventilation requires reaching higher oxygenation, it's usually at a price of increased dead space. And that increased dead space, on the other hand, leads to the difficulty to evacuate CO2. So together with the nutrition, you usually get increased hypocapnia. And that's the result of nutrition in those patients and increasing the dead space by increasing the PEEP.
Okay, thanks. So there is we have got a few minutes to keep with the other question. The question in this case is for short-term ventilation, if it is like lung recruitment effective and how to perform. My idea is that probably this question is related to the habit that we have often to do decremental PEEP trial for recruitment, incremental and decremental PEEP trial, but I don't know, what do you think, Domenico?
I think this is a really hard question to answer. In my understanding, is it if we are talking about recruiting maneuvers, so a very high amount of pressure for a short period of time. We have been facing in this year conditions in which we had to face very severe hypoxemia. So often we had to do it because we needed to save lives. So in case SpO2 is 50%, the patient is connected to the ventilator and you don't have any other way to support, I perfectly understand that rescue recruiting maneuvers to improve hypoxemia could be something to consider. Regarding the standardized recruiting maneuver and scheduled recruiting maneuvers, I think that we do not have final data about the role of PEEP in ARDS, and there has not been shown a benefit by high PEEP. For sure, we have seen a trial, which is the HART trial, published in the JAMA, in which high PEEP was combined to scheduled and very aggressive recruiting maneuvers. And this trial demonstrated that that strategy was harmful in terms of mortality. So I personally avoid using the recruiting maneuvers because we have physiologic data showing that you generate VD, so start of inflammation in the baby lung, even if the pressure is kept high for a very short period of time. And we have a randomized trial showing that a strategy including scheduled recruiting maneuvers is associated to worse survival. But I think that in the condition, in the individual patient, we don't have data to provide any final recommendation. And I perfectly understand that in clinical practice, once you have to face a life-threatening hypoxemia, this could be a solution to take.
Okay, thanks. The next question is, I think, for everybody, and it is what level of CO2 we accept in ARDS patients when we use low tidal volume?
If I may, that's a good question, and there is no good answer, because the concept of permissive hypocapnia and its physiological rationale is, in fact, admitting that we are helpless in some situations. So that's not the optimal situation, and we don't aim to have the hypercapnia. It's just the price that we have to pay for lung protective ventilation. And it, to large extent, it depends on patients' renal function, because as long as the patients can compensate their acidosis by preserved renal function, you can easily keep them on 60 millimeters of mercury. But while the renal function is impaired and the hypercapnia leads to acidosis, you usually get circulatory distress much faster in those patients. And those patients do not tolerate. So it's very individual, there is no good answer. But if I may refer to the recruitment maneuvers, is it allowed here to refer to recruitment maneuvers? Because I believe that recruitment maneuvers in general population are not a good idea. But we should keep in mind that there is a concept of focal and diffuse ARDS. And recruitment maneuvers, as well as higher PEEP, are usually of profit for those patients with diffuse ARDS. That is, the ARDS, which is a bit more homogeneous across the lungs. Whereas in those with focal ARDS, they are usually harmful, both high PEEP and recruitment maneuvers. But performing at least one recruitment maneuver may show you the point that you are at, whether you have the patient with a potential for recruitment or not. And also, if there is a huge potential for recruitment, it usually means that the PEEP that you use is just too low.
Okay, Konstantin, another question, very interesting question, is what about the inspiratory-respiratory ratio 1:1 when we ventilate a patient with a respiratory rate above 20 to improve oxygenation? The colleague asked if there is a benefit or if there are data on the use of this ratio 1:1.
In fact, there is some data on use of APRV, which is far beyond 1:1. This is usually 10:1 or even more. And there is a significant and increasing amount of data showing that it not only improves oxygenation, but that early application of APRV may also increase the survival rate. So that makes perfect sense. The problem is that APRV itself is based on the internal PEEP. So it's a bit counterintuitive mode, as the pressures that you use in lungs, you don't really see and you can hardly monitor. And also in 1:1 ventilation and high respiratory rate, I would be really afraid of air trapping and increasing intrinsic PEEP, and that would be absolutely against it. So rather a PRV than increasing the inspiratory rate, inspiratory time.
Okay, speaking about recruitment and COVID, there is a question on the opportunity of using recruitment for a patient with COVID-19. What do you think about?
It's the question whether COVID ARDS is the same as usual ARDS. And it seems that to some extent it's the same, especially in those patients with advanced forms and with increased elastance, that is decreased compliance and small baby line. So it may make sense, but in those patients with high compliance and low oxygenation, which seems to be associated with perfusion problems rather than ventilation problems, those recruitment maneuvers may be even harmful, in my opinion.
Yes, I think it is the question if COVID-19 is ARDS or is a new disease. Probably the truth is in the middle. I agree with you. There are different kind of. Domenico, somebody is asking if you have used APRV for severe hypoxia in COVID patients.
I have no experience on the, honestly, I have no experience on this. So we have been facing a pandemic, so a large amount of patients. So together we try to stick to guidelines. So try to keep the tidal volume at 6 milliliters per kilo and reduce in case the driving pressure was low. Extensive use of prone positioning, which I think is something that is really reasonable that works because we have been convincing data in the ARDS. I personally think that ARDS is heterogeneous and COVID-19 is a subset of ARDS, and some of the interventions with have been shown to work in the ARDS should be applied to COVID-19. Regarding APRV, I know there is a large trial on the cusp of publication, yes. But personally, I did not use it in the context of the pandemic, mostly because of safety reasons. So we prefer to have the tidal volume controlled when you have to look after a large amount of patients together. You look at the plateau pressure and you have the idea about the patient. So I think this is room for future to individualize treatment because I'm sure there are phenotypes of patients among ARDS. For some patients, it will be good for sure. For others, maybe not so good. But I think APRV could be in the future a way to treat a subset of ARDS patients indeed.
Okay, I think that we are, there is only one question, the last one, and it is how do you evaluate if a patient is a PEEP responder? I think that Domenico or Konstanty, you can decide who prefer to answer to this question.
As you wish.
Please.
Myself?
Yes.
So we do the single breath recruiting maneuver. So we usually ask. We know that as I showed in the slide. So we know that when PEEP is when PF ratio is greater than 200, I don't think that there is room for high PEEP. So we have data showing that there is really no room for high PEEP. We consider to use high PEEP when the PF ratio is below 150 milliliters of mercury. And in that case, we do a short 30-minute PEEP trial. So we just increase PEEP to 15 or 18 or to the maximum PEEP to maintain a plateau pressure below 28. After that, we perform an ABG. And we've seen very surprising results about the response to PEEP and the recruitability. And after that, we do that single breath, the recruiting maneuver as showed in the slides, and we calculate the recruitment to inflation ratio, so which is that parameter that at least identifies patients with a poor response to PEEP. In case the response to PEEP is this recruitment to inflation ratio is below 0.5, we use low PEEP, no doubt on this. And in case PEEP is, the recruitment to inflation ratio is greater than 0.5, so let's say 0.71, we consider the use of high PEEP. But what we have seen is that in COVID-19, there is a huge oxygenation response to PEEP. So we usually decide to prone the patient based on the PF ratio at low PEEP, because the risk is that you use high PEEP with a huge benefit on oxygenation, and then the PF ratio goes up and you do not prone the patient. So I would really strongly suggest to assess PF ratio at low PEEP and then prone the patient independently from the amount of PEEP used, and reevaluate the recruitability once the patient is prone. And we have recently had data from the group of Toronto showing that high PEEP in patients with a high potential for lung recruitment could be even more beneficial when you use prone position. So could redistribute the amount of tidal volume towards the back of the lung. So high PEEP and prone position may be, in patients with a high potential for lung recruitment, a tool to further protect the lung.
Okay. Okay, I think that we are gone through all the questions from the participant, and I would like to thank Konstanty SZULDRZYNSKI and Domenico GRIECO for their participation. I think that it was really, your speech were really interesting, and also the debate allowed to put out more specific clues to complete our speech on individualized lung protective ventilation. So thanks to everybody.
Thank you very much.
Thank you.
Thank you very much.
Thank you. Thank you to the SICM for organizing, and to you for chairing. Thanks.
Okay, thanks. Thanks to everybody for participating.